Okay. Thank you, everyone, for being here today. We appreciate your time. I know that many of you were here for the meeting that we held several weeks ago, but we do have some new faces based on discussion and wanting to broaden the input as much as we can for the committee work for this particular rule segment. I'd like to take just a moment, if it's okay, to go around the boxes. I know we did part of this last time, but if you could just share your name and region or practice setting to give everyone a sense of who's in the room, which perspectives are being represented. That also helps us keep track of other voices that we'll want to pull into the conversation as we go through the process. So since I know we all have different orders, I can go ahead and list names to get us started. So Joni, you're my first square.
If I can get unmuted. Good afternoon, everyone. My name is Joni Kalis, and I'm a physical therapist in Lincoln City, Oregon. And our practice setting is both outpatient and inpatient in a critical access hospital.
Thank you, Joni. Deirdre?
Hi, Deidre Nixon. I'm a physical therapist at Medford Children's Therapy in Medford, Oregon. We're a nonprofit pediatric physical and occupational therapy clinic, primarily serving developmental disabilities.
Thank you. Joel?
Hi, I'm Joel Williams, rehab supervisor and physical therapist for Providence in the outpatient setting with PTOT, speech, and some audiology within our groups.
Great. Jeannie?
Jeannie Thompson, physical therapist assistant. I'm a retired educator from Mount Hood Community College and also clinical background in outpatient orthopedics. And I currently hold a national position with APTA for PTA representation.
Thank you. Deborah?
Thank you. I'm Deborah Fitzgibbons. You can call me Deb. I am the coordinator for RSOI, that's Regional and Statewide Services for Students with Orthopedic Impairment, a grant through Oregon Department of Education. So the focus is supporting therapists across the state in the work that they do through professional development. I am not a therapist, but I'm in their boat and support them.
Thank you. Jessica?
I'm Jessica Deffett. I'm a special education coordinator at Northwest Regional ESD. So I'm actually a speech therapist by background, but I supervise physical therapists and OTs and PTAs and OTAs. And we serve like 20 school districts in Northwest Oregon.
Great. Jennifer?
Hi, everyone. I'm Jennifer Jolkowski. I'm a PTA. Former board member for 8 years, and I think I was involved when some of these rules were first getting started, so things have changed a bit. I have 35 years experience, but most of it's in skilled facilities, inpatient rehab, and then 12 years in outpatient ortho, which is where I am now.
Thank you. Erin?
Hi all, I'm Erin Bompiani. I'm a physical therapist and I work in the DPT program at Pacific University in the Portland area. And my clinical specialty is in pediatrics. And I also do some work supporting therapists who work in educational and early childhood settings. And I've been doing that for quite some time. And I also serve on the board of directors for the National APTA Pediatrics Organization.
Scott?
My name is Scott Taylor. I work in Sherwood at an orthopedic outpatient setting.
Thank you. Alan?
My fingers are frozen apparently with the
Okay.
weather. Sorry, guys. My name is Alan McAvoy. I'm a PT. I work in home health, and I'm currently hiding in my garage so my kids can't find me.
Do you have heat in your garage, Ellen?
I do. I have a little heater right next to me. It's
Oh,
just
good.
magic. Yeah, it's good.
Good. Shan?
Hi, I'm Cheyenne Blessing. I work at acute care as a physical therapist at Randall Children's Hospital. So I work in the ICU and critical care environments, but then also through more medically stable floors. See orthos, traumas, oncology, cardiac, just kind of the whole range of things. And then I also work on call at Vibra in long-term acute care. So I work with adults, similar, lots of different kind of diagnoses, but I see a lot of neuro patients there as well.
Great, thank you. And Kathy?
Hi, I'm Kathy Wijaya, and I work in acute care.
Great. Thank you, everyone. Michelle Sigmund Gaines, I work with the board, and I think everybody here knows Sherry. On behalf of both of us, just again, thank you for being here tonight. What we want to do today is have the listening and session to gather your input. I know that everybody had a chance to at least look at some of the rules in Division 40 of Chapter 848. I know many of you have provided written input, either based on that or in recent written statements to the board. So we have that written material. What we'd like to do tonight is do the walkthrough and have a group discussion through the full rule set in Division 40. What we'll then do with that is take all of the comments, the written ones that have been provided to us, your verbal comments today, and we'll aggregate that into a single document, highlighting areas that are questions, concerns, problems, where there may be a split where it works one way in one practice setting and a different way in another practice setting that we need to identify and make sure that it addresses those variations effectively. So what we're not going to do today is get into any sort of final solution or exact rule language. It really is to keep it open-ended and get the discussion and sort of all of the problems or questions that we have at this point before we start to boil that down into the next step where we would begin to translate that into new language. So what my proposal to facilitate that is to walk effectively through the rules on the screen, and then I'll ask the group if anyone has any particular questions or things that they would like to flag. We're recording this so that we don't have to take the time to do a markup or on the screen today. We can just keep the conversation going and have that discussion and that feedback. Once we get to the end of the document, we can have some summary discussion, or if anybody wants to go back to a particular thing or additional information you might want to bring into the Rule Advisory Committee process, we'll discuss that. And then we'll be done for the evening. And we will move to doing the internal work to take all this information and be able to present back to you that aggregate for input. And then we'll move to the next step of, getting into the nitty gritty of new proposed language for the board to consider. Any kind of questions about that process? All right, Joni.
Just a quick one. So do you want us to speak to some of the things that we've already provided you feedback in writing?
You can, absolutely. You don't, and we have the detail that you provided before. I think what you could do at this point is, to the extent that we can get input from others of making sure we're identifying the problem areas, you don't have to go into all of the levels of detail that you may have provided in writing. Okay. So definitions are always fun. I'll just start us in this section. Was there anything in the definitions that are visible on the screen 1 through 8 that anyone had a particular concern with or question about? Joni?
Mute button. Just I think it's confusing to have a record and then a permanent record.
Okay. Thank you. I'm letting somebody else on a phone into the meeting room. Kathy.
I had a coworker who looked at this as well, call out, is it considered duplication of services if physical therapy is doing a functional task that's related to a IADL or ADL movement, and the patient is also getting occupational therapy at the same time?
Okay. Thank you. Any other comments on this? I'll scroll us forward. Maybe look away for a moment. Joni?
Just that number 8 there under physical therapy interventions, it looks like an older definition of the practice of physical therapy in the Model Practice Act. And so I'm wondering if you'd want to update this to the new number 7 version.
Okay. Thank you.
Michelle, this is Alan. I have a quick small one, but it's a nuance that came up recently in practice, just about the removal of sutures. And I think Sherry directed me towards line item 8 and the component that indicates integumentary repair and protective techniques. It seems like it perhaps lacking a little bit of, perhaps there could be more oomph to that.
Okay. Okay, great.
More specificity.
Absolutely.
Michelle, can I just ask whoever joined on the phone to introduce themselves, just so I can write it down for the attendance?
Yeah, I believe that was me. This is Ryan Abbott. I'm a physical therapist, and I work at Providence Bridgeport Rehab in outpatient.
Hi, Ryan. Welcome.
Thank you.
And we have Amina is joining us. I think to Joni's point, probably number 13, I believe that's been updated in the Model Practice Act as well. So that may be something that under telehealth service should be looked at as well from other input we've gotten. And for those of you who have just joined, what we're doing at this point is just a scroll through of the document as a listening session. So as we go through on the screen, it's a chance for comment or questions about any of the rules. We really are looking for your experiences in the different settings that you or your coworkers or others have had questions about, a rule that may seem ambiguous or something that seems dated because practice has shifted from when the rules were created. So as I go through, please feel free to comment. We're recording and capturing all of this, and then we'll aggregate it, synthesize it, and bring it back to everyone for review. So with that, I'm going to go ahead and move us into the next section, the general standards of practice under 0105. And any kind of questions or areas of concern that anyone has run into? Jeannie?
Yeah, my question refers to number 2, which talks about the physical therapist referring a patient back to a medical provider. And it led me to think about the point in time when the PTA is responsible for bringing the physical therapist back into a treatment. So not directly related to this, but when I had that thought, I went back through the rest of this document and also the role of the PTA, the state statute for what a PTA is responsible for. And I can't seem to find anything that talks about the PTA's responsibility to bring the PT back into treatment when there's a concern about patient progress. I don't know if that's something that belongs here in the legalese, but it was something that I thought about when I read this one.
Okay, great, thank you. Any other thoughts or comments for this section? Joni?
Just something small, but on number 1, licensees shall practice competently. So do we need a definition of competence?
Okay. Thank you. Any other thoughts or discussion on this section? Kathy?
I actually put it down in my notes to ask a little later, but I think it'd be appropriate potentially in this section as well. Basically, under what circumstances would we need a list of precautions from a provider that ordered therapy?
Okay. And what else? Okay, for me to move to the next section. I know we're getting up to some of the meat of it. Yes. And I know much of this language is coming directly out of the Oregon Health Authority's statutes and rules. But any kind of questions? Erin?
Yeah, sorry, I was slow in trying to find all my buttons. Just back to the last section.
Yes, ma'am.
Yeah, display of license. I'm just wondering, for people who are going into, doing home health or in early childhood are going into the homes, there really isn't an opportunity for public to view those licenses. And I don't know where they're being displayed or if anybody's made aware of that.
Okay. Thank you. And it's absolutely no problem to go back at any point. I'll move us just to anything else where there have been issues or concerns with regard to the use of healthcare interpreters. I know that did get cleaned up by the legislature. The first version of it made it very problematic in the school setting, which we were able to kind of address in the rule. But... Okay. Then I'm gonna, Amina?
Yes, I did have a question. Is there anything that addresses bilingual providers when they're interpreting? I mean, they're using their native language to communicate with patients. Because as of right now, we are required to still fill the interpreting area, with our name, but I don't see at least addressed on this. I
Yeah,
don't know if it's necessary. Mhm.
it's a good question. I will flag that for follow-up. I believe that the Oregon Health Authority is trying to require providers to use folks that are on the list. So I think it may depend on whether there's been a certain level of training or registration for the individual.
Mhm.
But I'll flag that to be able to follow up, because if it's clear in their statutes, we can make it more clear here.
Okay, thank you.
Absolutely. What else? I will bring us forward, but again, I can go back at any time. I apologize. We'll go into the general standards for record keeping. Jessica.
So number 3 just came up for me because the date that the service was provided, we put that in our records in school. We've never put in the date that the entry was made in the record. I don't think my PTs know that. And so we can, I guess, but there's no place for that in our records, and we do records very differently, I think, than like medical settings. And it made me wonder, like, is that absolutely necessary in our setting, or like, do we need to kind of change that? Or yeah, just made me wonder about the rule.
Okay, great. Jeannie?
Mine is also relevant to number 3, but I'm interpreting some contradiction between 2 and 3. Let me get to my doc here. So 2 says that the record has to show the date a physical therapy service is provided. And then number 3 says the date the service was provided and the date the entry was made have to be in the record. But isn't that contradictory to say that you have to put it in on the provided date, but then later you're putting an entry date? I guess I don't understand. If number 2 says do one thing and number 3 says do something that sounds different to me.
Appreciate it. I saw Joni and then Cheyenne.
Yeah, concurring with Jeannie, 2 and 3 are contradictory. 1 says completely your record in the same day, which makes sense to me. That's in the best interest of the patient. Number 3 says you have up to 7 days. And it's a huge problem in our system because it is delaying authorizations for patients. Care is being delayed. People don't know if you should do it on the same day, or do I have a week, or heck, maybe I have 2 weeks. It's very challenging.
Okay, thank you. Cheyenne?
Yeah, and then just to echo what's been said, just the difference in something a record being made on the day of service, but then you have 7 days to put something in the permanent record. I think that goes back into the definitions of what's a record and what's a permanent record. So I think having a clear definition for those 2 things would help clear up these 2 items. And then for myself in an acute care setting, along with a lot of our other providers in acute care, I couldn't wait to document 7 days later, because at that point the patient had already changed so much. So I feel like it would be within best practice to have a note written in the record on the day of service.
Thank you. Hamina, Alan, and then Aaron.
What I was gonna add is that it would be good to have a clear or clarification what is to prepare within 7 calendar days and what is to have it completed. For outpatient departments, they can see a patient, and if someone leaves a chart open and can come back the next day and complete it, prepare and complete it are different. So I think a clarification of when they need to close those notes would be important.
Okay, thank you. Alan?
She stole mine. That was it. Yeah, prepare and complete. It feels like there's something missing there.
Okay.
Thank you.
And Aaron?
Yeah, just to speak more to the pediatric and educational setting specifically, a lot of times the types of evaluations and assessments that are happening are team-based and may occur over more than one day and may not be realistic. It often wouldn't be realistic to document in that same day for those types of things. So I definitely hear in other settings where that would be essential, and in these practice settings, it might be impossible.
Okay. Thank you. And I just want to note Jessica has added in the chat, kind of pulling into the other location about the treatment records having to be documented within that 1 week. So I think that falls in, Jessica, right, with some of these other comments.
Yeah, that was a little, I think, on that discussion, and then kind of what Erin is saying, in school age we have the same issue, not with just evaluation, but also with treatment and issues that come up like at the end of the day, and when we're hiring contractors versus direct hired by the school district, we don't do any sort of overtime for them because it goes into time and a half. There's all kinds of budgetary issues, but that becomes a thing where, like, if we had to have them stay after the meeting to do their records, there's just a lot of implications there. So we've gone with the 7 days, but clarification would be great.
Okay. Alan?
No, I think I just maybe I didn't put my hand down, but I did have another comment regarding section 6, and just again the word prepared. I'm wondering if there are certain instances where it should be looked at as maybe we could swap it out with the word complete.
Okay. Amina?
Yeah, I had a question example. You know, we have the wheelchair seating clinic, and it requires multiple. You know, we have a vendor, we have the patient, we have authorization for health insurance and whatnot. So what I'm finding is my therapists that do the wheelchair seating clinic, you know, they have this 2 or 3 hour long appointment. It takes them longer to complete the evaluation, and then they're waiting on the vendors to like find if they can get that part of the chair. So they can't really close their notes because they're missing information. So it's a constant struggle that we're, you know, trying to navigate, and, you know, they end up going into overtime just to stay compliant. So I think that would be very important to take into consideration of what's the window for those kind of cases when they're, you know, a therapist is tied up to, you know, a vendor, for example.
Thank you. Thank you. That's helpful. Other thoughts or comments or even questions for each other about the comments that are being made?
Michelle, this is Sherry. I just wanted to bring up something that's actually not a rule and not listed here. And it's come up a couple of different times with questions to me about, and I'm really curious to hear from the group about recording time in and time out of a treatment session. It's not something we require now. It's come up in you know, cases when a patient would say, I was only there 20 minutes, but I got billed for an hour. Or, you know, they said I was there an hour, but that's not accurate. Or it was, you know, this time of day, but, you know, some inconsistencies with the time of day. So I'm just curious what people think about. I think most insurance is required. I think a lot of EMRs shows up anyway. So I'm just curious what everybody thinks about that.
So I've got Joni, Alan, then Jessica so far.
Yeah, no, Sherry, I think that's a great point. I think that we should be documenting time in and time out, and even further to get us more consistent with Medicare. We should be having the amount of time spent on timed codes for sure, and probably untimed as well.
Alan?
Yeah, it's a good pickup. I see that, yeah, we've got everything from date and content, but not about the timing. So that's good. I want to mention something. It's more of a putting it out there to the group. Does anybody know of, or do we have a resource for what are considered the recognized standard physical therapy abbreviations? This is going off of line item 8, because it seems to be an evolving thing.
Good question. Jessica, then Hamina.
I had a different comment, but based on what Alan just said, so helpful, because that comes up all the time with our evaluation reports and like notes, and I'm telling my people like, I have to read this and I don't know what you mean. So make sure it's something everybody else recognizes. My comment is to Sherry's question about the time in, time out. The way that we work in educational settings, and this is true for early childhood as well as school age, is that our therapists are in and out of settings and consultations and meetings and working with kids, and it's not clean, and it's not something that you can often look back at your calendar and be like, oh, that was my 3 o'clock. And so I see that as just adding an incredible amount of tracking and documentation for them if they were having to keep track of like, well, it was 1:37 to 2:14 today, and trying to figure that out and document it. However, I will say that in the school setting, because sometimes people bill Medicaid, we don't currently. And so maybe if there was a need for that, it could be tied to when a reimbursement code is being used or something. What we do in the school setting and in early childhood is keep track of our IEP and IFSP minutes. And because those are kind of like, you know, on the service plan, the child is getting 20 minutes a week or 700 minutes a year or whatever it is, they're documenting, I did 20 minutes today, or I did 40 minutes out of my 700 for the year, but not the time in and time out. So I wanted to kind of put that out there of what that would add to people in that setting.
Thank you. Maria?
For our clinic and outpatients, we already have made changes to be in alignment with Medicare guidelines, just because it makes it easier to prevent mistakes that way. So we time in, we time out, we have total time, and then specific treatment times and amount. So we wouldn't really add or change. We just figured that that was like the easiest way to stay compliant with Medicare, which is a big part of our patient population.
Thank you. Joel, Scott, then Kathy.
Yeah, I'll just echo Hamina on, you know, in our EMR and outpatient, that's already recorded, and we have to be careful of overruling, you know, things. But Sherry definitely has a point that that's important to be able to track that. And I think, you know, maybe a recommendation versus a rule probably be the best way to go on that.
Okay. Scott?
I think keeping track of time in, time out can be really tedious and also set yourself up for a lot of errors, just because it's often hard to say exactly when they come in, come out, make sure we're marking it at the correct time. Sometimes we get really busy and unable to do that accurately.
Okay. Thank you. Kathy?
I wanted to bring up, I'm not sure if this was driven by Medicare or if it was our company, but the patients now have access to read their notes basically immediately after they're written. And this is an acute care hospital setting. So that's something we definitely keep in mind when it comes to abbreviations. So we're not using something like shortness of breath abbreviation, because that could be misunderstood by a family. So maybe just something to consider when we talk about abbreviations.
Good point. Thank you. I'm going to just scroll up a little here so we can see the lower sections, but right there. And Kathy, did you have another comment, or was that?
Nope, just need to lower.
Okay, Jessica, then Aaron.
Okay, so mine is on 15, the keeping things for 7 years. This is a question that comes up for, and I don't know if it happens in other settings, but like what exactly has to be kept. So when my PTs do an evaluation, a lot of times it's functional and they'll just write the report. Those reports, as well as service notes, are being kept for 7 years, but they will have a question about if they use a standardized assessment and there's like a protocol that they filled out. Kind of our special education guidance is like shred the protocol once you've summarized the notes in the official report. The report is what gets kept. But they've had this question sometimes individuals about, I don't know, my license says I need to keep everything, like including any sticky notes I wrote on. So just kind of clarity on what exactly has to be kept might be a little bit helpful there.
Okay, thank you. Erin.
So Jessica, what you said before, I agree with your previous comment, everything with that for sure. Because of the nature of being in early childhood and school-based, it would be quite challenging to even accurately know how to do that, and the job role just includes so much more. To the point that you just made, I was advised when I was in early childhood to shred my standardized assessments as well. The problem with that is that if you're using it in a way where you're trying to monitor a child over time and you're discarding their original raw score, then you don't know what they did the previous time, and then you don't have that data to compare to. So I understand the problem of saving that for so long, but I also think it could be problematic to advise to get rid of it while they're still actively working with the patient. So maybe it's something where, supporting documentation like that would be kept until the plan of care was closed, and then the permanent record needs to be saved for a longer amount of time. Then I had one more that went out of my head. Oh, just with abbreviations. We still are teaching them to DPT students. In pediatrics, I encourage students to not use them at all for more inclusive documentation. And if a family is reading that note, to be able to actually understand what it says. And I think with the point that was made with more patients having access to their records, I think that's something we need to be considering, is the impact of those abbreviations potentially on the public understanding their record.
Great, thank you. Joni.
Just a comment on, we've got record, we've got permanent record, we've got patient records. Maybe pulling that together and having one record. Call me crazy.
You've got lots of nodding heads there as well. Anything else on this section that comes to mind right now? Okay, I'll go ahead and scroll forward. Watch your eyes. Standards for authorization. Jeannie.
So the very first line says, as a result, and change effective on January 2014. Can we just ditch that whole thing? I mean, like, are we long enough away from 2014 that can be alleviated?
Okay. Thank you. Other thoughts? Kathy.
So this is where in my notes to myself, I made the comment about precautions, because 1B states, if the referral or authorization specifies or identifies and it listed precautions, interventions, then that needs to be followed and nothing done beyond that. But there's no statement as to when we would need those. So just bring that up again.
Thank you.
Shell, I was just thinking as we're looking, particularly at this rule, when Jeannie brought up do we need the part about the 2014? Can you scroll to like the bottom of this particular section? I just wanted people to see like all of these things written down the bottom and what that means. Like, and those are all the times that something in this rule has been changed. So there's a way to look at that and see what statute relates to these rules, and then what's the history of the last time any changes were made in this section. Did I get that right 100%, Michelle?
Yeah, the first part of the number, the Secretary of State's records division, or the rules division, pardon me. This part of the number references that specific filing. So that was our board. This was the 8th rulemaking action in 2005. And so with that number, Secretary of State's could pull that particular filing. The F is that it was filed initially on this date and then certified effective on this date. The difference between when we submitted the rules and when we said the rules went into effect.
Thank you.
Absolutely. I'll scroll back up here just a little bit. Anything else for this section?
Yeah, for on E, where it says a physical therapist shall immediately refer a patient to a provider if the patient exhibits symptoms. For C, where it says for which treatment is outside that therapist's knowledge, skill, or abilities, I feel like there's some subjectiveness to those qualifications. And similar to how one of the rules said a physical therapist should practice competently, I feel like maybe there should be a clearer definition there of at what point is it without that therapist's knowledge, skill, or abilities.
Okay, thank you. Other thoughts or comments on either Cheyenne's point or other sections? Scott?
Can somebody explain what the 3 means down at the bottom, what that rule is, the very bottom?
It's basically saying that irrespective of all the things in this rule that it says that you can do, you can't do it unless you meet the criteria in this other section of Oregon law.
Could you say that again, please, Michelle?
Yeah. And I think one of the things that we can do with this is to flag, it's not clear. But whenever, notwithstanding everything we said you could do or how you could do it, you can't do it for an injured worker that would fall under this other Oregon law unless the specific governing managed care organization is under contract and authorized to do it. So in a way, it's saying that this other Oregon law, chapter 656, which is outside the PT scope, is controlling worker injury and who can do what. And so there's nothing in the PT scope of practice that overrides that, irrespective of what's been said in the rule or notwithstanding what's on this page. You still can't do it unless they say you can.
I do think it's a good thing to flag just to make sure that that is hasn't changed, that statute.
Yeah. And it is anytime you see
statute, even though
yeah, that it's still the same criteria. Anytime we see language like notwithstanding or pursuant to, right, the very legalese. And so anytime we can replace that with plain English, plain language, I think we can take the opportunity to do that as well. Thanks, Scott. Anything else for this section? Gonna scroll to the next one. Standards for record of authorization. Judy?
Just a really small point on number 3. An oral referral must be followed up with a written referral. Do we want a time frame on that?
Okay. Thank you. Kathy?
I'm curious why a written referral doesn't need to have frequency and duration. Oh, it does say if specified. In number 2, it calls out frequency and duration, but it says if specified. So never mind.
I think we should just note too, I'm putting a note here. I have gotten a lot of questions about who can document the referral. Like who can be the person who actually writes it in the chart or takes it on the phone.
Or request it even.
Right, that too, Alan, you're right.
Okay. Thank you, Sherry. Okay, I'll roll that forward, but if anybody has any other thoughts, I can go back. I'll move us to 0125. Oh, Joni?
Sorry, slow. Back to 3 again. And then what would be the considerations for patients who are just self-referred and didn't have a referral?
And you have to document the self-referral. Yeah. Okay, Scott?
If we do put a timeline on that number 3, then who's at fault in a sense? Because sometimes it's really hard to get the provider to sign a referral or to send one back. And do we just stop seeing the patient at that point?
Good question. Thank you.
Yeah.
Okay. Standards for initiation, documentation of initiation. Scott, did you have a comment here or was that? No, okay, Hamina and then Aaron.
Yeah, I was gonna go back with to what Scott just said. It's very common that we do have to chase those providers to sign the referral, the notes. So maybe even having, if we're trying to stay in compliance, by sending this and doing the phone calls and we have a record of that contact, that would still keep us in compliance, even if those providers are taking longer.
Okay.
If that was taken into consideration, I think it would ease some nervousness around this.
Okay. Aaron, then Joni.
I think this fits with number 2, and I think there's some additional language elsewhere that relates to it, but there's a lot of confusion a lot of times from IEP and IFSP teams as far as what information they can use and include. Like, for example, in an early childhood setting, an initial evaluation doesn't to get into the services does not have to include a physical therapist. So sometimes teams are, an SLP and maybe a teacher, and they're doing that evaluation, but using information from other places. So there's just a lot of confusion there as far as how much of that can inform an evaluation that would then have a referral to a physical therapist to do service, where then they have to perform another new initial evaluation to start the treatment. So it's the IFSP IEP language does not line up well with the rest of our documentation.
Okay. Thank you. Joni.
Yeah, a follow-up question for Yimena. When you said you were having to chase down physicians to get, signatures, are you thinking about signatures on the plan of care for Medicare, like a certification,
Yes.
which is different than a referral?
Yeah, but for those self-referred patients, there are, they come in, even if it's a Medicare patient, they can come in and get evaluated, and then you send the plan of care out, which, creates the referral that way. That's what I meant by that.
Thank you for that.
Okay.
Other questions or discussion? I'm going to scroll the page up just a little bit to see more of this section. Scott.
Kind of things do we have? I guess let me see where that went. We have to perform an initial evaluation after the patient has been discharged. What if you discharge them and then 4 days later they call you up and they're like, oh, it's back. Pain returned. Do we need to perform an initial evaluation for that? Can we just omit the discharge?
Okay.
Of course, that leads me down to our discharge section when we get there, but
Joel?
Yeah, that's a really common issue in outpatient, really common.
Okay. Thank you. Anything else for this section? Okay. I'll move it forward, but we can always loop back. Initial eval. Jeannie?
Number 1, patient's full name, age, and sex. I'm curious about the use of the word sex, whether or not that's necessary, and if it is necessary, is there a different word that we could use so that we're being cognizant of how people are identifying, or, any of the other things that are changing in our society these days?
Thank you. Erin?
Number 9 is something that is really problematic and comes up a lot with therapists in these early childhood and educational settings. I think when this was changed initially to include things like allowing goals to be written and the plan of care to be included as the IEP or IFSP, that was in an attempt to make things easier. However, sometimes the things that are written in that document don't outline the plan of care for the physical therapist specifically. And so it isn't clear for record keeping what exactly should be done. And when we talk about this, and Sherry's been involved in some of these conversations, what's really advised is that oftentimes the therapist has to keep separate records to meet the need of what we're really looking for here. So I think that needs to be teased out a little bit more.
Okay, thank you. Joni?
When I just kind of think about this entire section, I'm wondering if there's maybe generic language that we could use that talks about performing an initial evaluation instead of such a detailed laundry list.
Okay. Other thoughts on that? I'm seeing some head nods. Amina.
The only other thing that I'm thinking, also to stay in alignment with Medicare guidelines is the date of service and expected plan of care dates. That's
Okay.
something that we also add, that right now is not required by the board, but it is required by Medicare and several insurance as well.
Okay. Alan and did you have a?
Can you scroll back up to the section about therapists shall, it's just a few, you're getting warmer. Okay, right there. All right. Yeah, a current patient presents with a new diagnosis for an unrelated body part. It sounds, I feel like the language could be better there. I don't have a real clear bit of advice to offer, but in many settings, of course, we're dealing with, maybe a change in neurological condition. And so I feel like body part, like it's a little bit too narrow, but also I wonder about the concept of a whole new evaluation, separate initial evaluation. We wouldn't even be able to do in our setting in home health with home care, home base. I think we'd actually have to discharge the patient and readmit them to be able to technically do another initial evaluation. We could do reassessment visits and then within that incorporate the new diagnosis and then set goals accordingly. But there's a little bit of a barrier there that's set within the software.
So I have
and go.
Okay. I have Kathy, Joni, then Hamina.
So that actually reminded me, I'll say two things now related to the comment Ellen just made. We've been looking at ICD-9 codes, and if you look at the initial eval and reassessment for ICD-9 codes, I believe what's in here actually aligns with that. So just wondering if consideration is made to ICD-9 codes or 10, whatever number we're at now, when these are reviewed. So just calling that out. And then in regards to the documentation, if you, I wouldn't mind going back down. So in 4, it does call out if otherwise accessible in another part of the patient's medical record. So again, in acute care, we have the hospital chart. So typically we don't call out referral source and that type of thing. So it'd be nice if it was in here that for not everything, we want name, age, but if it could be commented that if this is available in another part of the chart, it doesn't need to be restated in the physical therapy note.
Okay, thank you. Joni.
Yeah, just a response again to Alan's comment. Because I feel like if somebody's, let's say, being seen for their shoulder and then now they're having ankle issues and you want to take care of them for that the patient deserves having that body part, a full exam. You might not be able to bill for it. But I mean, share with me more.
You're saying you're not being able to bill for it if we're going away from, say, someone with a patellofemoral syndrome and now we have a rotator cuff impairment and being able to bill for the two separate. Is that what you're asking about, Joni? Sorry.
No, and I think it may just be my misunderstanding because I mean, I feel like the patient would deserve an evaluation of that body part so that you would provide it adequate treatment, documenting objective findings and so.
Yeah. I'll say, yeah, maybe I didn't explain clearly. So it's not about what they deserve. It's just it's a limitation within the software for us to be able to do an initial evaluation on someone who's actively a patient. There isn't an option that I know of to be able to do that. I totally agree with you. They obviously need to be thoroughly assessed. So we can certainly pull our reassessment forms, which which the 30-day reassessment form really is what it is, but it allows us to reestablish and revisit the current goals, but also set new goals according to the new diagnosis. But there is a limitation there on our end, on the software end of things. But just wondering what might we be able to document in our in Division 40 here that might allow for some mobility within that. I'm not sure. I'm not really saying that clearly, but it's a bit of a barrier for us in the home health setting.
Alan, it sounds like the way the software is designed, it makes an assumption that there can only ever be one initial event.
Right. Correct.
And then the software thinks that a reevaluation, that if there's a new element, it gets added into that continuum of treatment, so that it thinks that you're reevaluating, setting new goals, incorporating that new information. And so initial here is what's problematic.
And it's not even there is a form that's designated as, they found me. So there's we have forms that are called not to monopolize too much time here, but add-on evaluations. Of course, there's the startup care oasis evaluation, but we don't have initial evaluation forms. So I guess it's a matter of defining what that would be exactly. What is an initial evaluation, or would a thorough reassessment satisfy that particular line item to appropriately incorporate the new diagnosis?
Okay, I mean,
I would add that it would be good to have, when appropriate, to be able to do, when you have a new diagnosis, to be able to do a progress note or reassessment instead of initial evaluation if it's related to the initial injury. Let's say you're having, a shoulder patient, and then compensation, they come with your, cervical spine, and instead of doing a whole new evaluation, you just do a progress note to add that diagnosis. I don't know that was added there, but at least adding the verbiage, when appropriate, completing a progress note or reassessment instead of initial evaluation, was just a thought.
okay. What else? And I know I'll say this again, I really appreciate all of you for taking your time to go through rules on a Thursday night.
I wanted to piggyback on that and say this is great, and I'm taking like really good notes, and also super happy that we are recording this. I was like, did I get that? Did I get that? Did I get that? So I'm really glad that we're recording.
Yeah. Okay, I'll scroll forward, but as you know, I'll jump back and forth. So watch your eyes, and we'll get to standards for plan of care. Jessica.
All right, so I'm going to preface this by saying I absolutely know this is a can of worms. I already opened it with Deb. We've had some confusion, and Erin actually probably maybe said this more succinctly than I'm going to, but I want to just add to it and make sure it's part of what we're dealing with. We've had some confusion, I think, across Oregon in regard to like the IFSP and IEP, whether it can be part of the plan of care or substitute for the plan of care. Right now, we have some RSOI guidance documents that say it can be the plan of care, and that may or may not, be something that we clarify within the rules. It can just be confusion that's kind of been institutionalized over time and not Deb's fault in any way. But just admit I opened this can of worms. But part of the difficulty that we run into is that a lot, like in my region, and I think a lot of the places around the state, our physical therapists are working in a consultation model. And what ends up happening, and I realize we're on 35 right now, and it's called out in 40 that there need to be treatment goals. And in the consultation model, there's often not a physical therapy goal at all on that IFSP or IEP. And then it kind of becomes this question of like, okay, so what documentation, what does it look like then to have a plan of care if you're calling the IEP your plan of care, but it just says physical therapy services and nobody besides the PT knows exactly what they're doing. So I'm gonna maybe stop there. I think maybe I got it, but Erin's gonna chip in and, and say what I missed.
Okay, we'll do Cheyenne and then Erin.
Under number 5, where it says PT can make modifications to the plan of care anytime there are significant changes in condition or status that would affect the goals. Kind of going off the previous conversation of at what point do we initiate a re-eval? I think if a patient's status has changed so much that their plan of care needs to change and their goals need to change, is that actually an appropriate time to reevaluate the patient? So yeah, I think maybe just clarifying that or adding it into the previous section.
Okay, thank you. Erin.
Yeah, so this is definitely related to what I said before and Jessica's comment. I do think we need to define that a little bit more. Another thing that has changed since this was written initially is there's a big push for best practice standards in these settings to include collaborative goals. So actually an IEP or IFSP should not have a PT specific goal on it. It should be the team's goal, the child's goal, and then the therapist is supporting that. The problem is there's nowhere to really document what that will look like that would align with what we need to provide for our practice act. So often that needs to be supplemental documentation. So therapists get very confused, and in my experience, many of them are not adequately documenting what they're doing.
Okay, thank you. Amina.
Yeah, I would like to go back to number 5. I also had a comment about that. In the page before, we talked about changing in diagnosis and doing like another initial evaluation. In this case, I think it would be good to clarify if it's, says therapist shall make modifications to the plan of care anytime there is a significant changes in the patient condition or status. If the change is like, for example, a treatment that you want to add that maybe wasn't added on the initial evaluation, but so it doesn't require a full-on progress note to add a treatment that maybe wasn't included initially. But then if it's a change of diagnosis, then it requires a progress note. Just thinking about the amount of paperwork that everyone has in not trying to add another requirement to add, do progress notes more often.
Mm-hmm.
So maybe making the clarification on that.
Okay, thank you. I'm going to, since they are connected, I'm just going to scroll so we can see a little more about the documentation of the plan of care. I know some of the comments have touched on both parts here, but anything else specifically under 140?
I just wanted to note there's, if we're looking at the rules of record, permanent record, patient record, this rule has the word permanent record in it.
Yep. Joni?
Just being nitpicky, but on B, maybe proposed interventions.
Okay. Thank you. What else? Jeannie?
So I actually have a process question based on what Sherry was just saying. So when this process moves on to the next place, I made an assumption then that somebody goes back through the whole thing, say this has changed, say permanent record has changed and there's new language that's created. Isn't it part of the process to go back and change it every place that already appears?
Yes, I think that we would just need to make sure what was meant here when permanent record was used. And if we're changing the definitions or combining it, we'll have to make sure that it has the same meaning in the context.
Okay.
So kind of it's both and.
Okay. Okay. Thank you.
Absolutely. Jessica and Kathy.
So on C under 140, we've gotten the guidance from ODE on how we write the frequency on the IEPs and IFSPs has changed, and it kind of is cyclical. So sometimes they'll say, but what does come up is a lot of times our PTs will write minutes per year, and it might look like, 120 minutes a year, might look like 700 minutes a year. And my wondering is whether or not that actually meets the criteria of, the duration shows it's from this period to this period, because the document is good for 1 year. It doesn't really say frequency, or let the consumer, the family or student in this case, know how often to expect those PT visits. And sometimes, we're working with board guidance and ODE guidance. Sometimes ODE will come through and say, like, well, that's not adequate and you need to be putting it in terms of, per week or per month, and sometimes not. And so I guess my wondering is whether or not that's meeting those expectations.
Okay. Thank you. Kathy?
I wonder about documentation that's required when it's a one and done type visit. So again, my focus is acute care, and sometimes it's just evaluation and discharge, but there are times it's evaluation, intervention, and discharge. So if we're not seeing them after that visit, does there need to be a plan of care in there? Does there need to be goals? In particular, it's usually stated in the assessment, the intervention that was provided and the outcome. So does it need to be restated saying it was met or done? Additionally in the note.
Okay, thank you.
That's a good point, Kathy, because that brings up evaluation, plan of care, note, and discharge, all in one person, in one visit.
And how to do that, yeah.
Right.
Deb.
Well, I know one of the questions that we often get is when do I need to make sure that I'm going back and getting the permission and updating permission from the family to do new things and add services, etc. And maybe I'm off base here, but when I look at number 5 and it says a physical therapist shall make modifications, is it implied that all along that they are going to make a modification because the team agrees on this and that the family has been part of that conversation?
Okay.
And Deb, I think that's the difference between PT documentation and a plan of care and the IEP IFSP, because to update what might just be basically how the PT is going to support that document, they should be able to update that as they see fit as they're progressing through the plan of care.
Okay.
But they definitely cannot update IEP or IFSP goals without recalling a meeting and having everyone sign off.
And so then therein lies part of the problem too, that if you say that the plan of care is the IEP, then it takes away or it changes the flexibility. Is that true?
Yes.
Thank you.
Scott. I think you're still on mute, Scott.
Sorry. Do we have a definition on what a significant change is?
Good question. Thank you. Other comments? Joni.
Well, and kind of coming off of Scott's comment, and I think someone else made a significant change in findings is one of Medicare's reasons that you would conduct a reevaluation. So there's some confusion that this isn't a plan of care section when you're really kind of talking about when you might conduct a reevaluation, which again, you know, Oregon doesn't really use the term reevaluation. They have reassessment, but that's a later section, but it does tie to that, number 5.
Okay, thank you.
And Joni, there is a similar rule there in the reassessment section. So, yeah, they are connected. I don't know if they need to be in both places or good point.
Okay, I will scroll us to 145. Standards for providing treatment. Alan. Oh. Alan must have dropped out. It's in the waiting room. I apologize, I'm a little distracted. I think somebody in my family is having ice trauma at the front door, so cross your fingers, everyone.
Michelle, do you want to take a quick break? Anyone else need to go to the bathroom or get a drink or something?
Do folks want a break? Yep, okay. Why don't we take 5 minutes and then we'll come back. Thank you, everyone. Okay. As folks are coming back, any other thoughts on standards for providing treatment? Deirdre?
Yes, on number 2, I think it's a little, needs to be a little more clarified because when you're talking about attempt to perform and then qualified education experience in that particular intervention, I mean, sometimes we have, in our setting, we've had people that had worked in skilled nursing and then they had a little bit of peds, but they wanted to dive more into peds. And we've been able to do like mentoring through our organization. But I don't know if that falls into this particular standard.
Okay. Thank you.
It's right alongside that competency nebulous.
Mm-hmm.
Yeah.
Yeah, because the foundation is, you know, they have the foundation, but, you know, have they used it in a play-based,
Right.
you know, or a play-based intervention?
Yeah. Or in the past 20 years. I mean,
Right. Exactly.
Thank you. Jennifer, then Aaron.
So I just wanted to give a little bit of background. I specifically remember us talking about this rule. One of the things that I think the big discussion had been is how do you know, and your physical therapist hopefully is the one that's driving all this, but how do you know who has what experience? And I think it's especially true coming with PTAs who have had 35 years experience or have taken certifications in certain interventions. So the question back then, and it still is like, how just, prescriptive do you want to be with that? And just thinking that as clinicians, but especially as the supervising therapists, is that they know their assistants well enough to know what they can delegate and what they can't. If you tend to make a lot more kind of prescriptive rules, I think then it just takes away from the therapist being able to manage their team and how things go. So just some thoughts on the wording of that and why it was sort of particularly meant to be a little bit ambiguous, so that the supervising PTs are the ones who are in charge of who's doing stuff and what interventions are being done.
Thank you. Erin.
Yeah, I want to echo what Deirdre said. They're being in a specialty area of practice, a graduating therapist in PT is not necessarily prepared if they haven't had training, mentoring, continuing education to be in a pediatric setting, let alone an educational setting. And it's something I encounter quite a bit, that roles are filled with contractors because it's hard to find people who have never worked with children, let alone now we have all of the added layers of an education system and law that they need to know and understand. And I think there really can be a risk to the public in that, and being, and not recognizing what they don't know. So some amount of a little bit more than with qualified education and experience, I agree, could be helpful.
Okay. Jennifer, did you have more to add?
Sorry, I had one more thing. Deb lost her power again, so she just wanted to let you all know that.
Oh, okay.
No.
Everyone think warm thoughts. And Jennifer, did you have more to add?
No, I'm good.
Okay. Anything else?
I was gonna ask if Jennifer's seen any typos yet. She's really good at finding those.
That's right.
No, I think I'm losing my touch.
Okay. I'll segue us into standard of treatment by a student PT or student PTA.
Well,
Yes, Deirdre.
I think this is the particular area where the reason why I'm here, basically, is we had issues with the supervision of the 30-day supervision issue, especially in our clinic. And we have in an underserved area, and it's hard to get PTs. So we're starting to rely on PTAs. And the way our clinic practices is, you have full caseload, hour sessions. It's really hard to reassess every 30 days of not only yours, but the PTAs directly on, where you have to have sight and be with the client. And it's made it very difficult for our clinic, not only just the logistics of it, but the cost, because supervising therapist has to get paid, but it's not billable. And so, we were trying to figure out if we could change it to not every 30 days, but to every 60 days, since it'll make it a little bit more manageable. And the school district or the school-based therapists, they're in that 60-day range as well. So you know, how difficult would that be to kind of incorporate us? Because most of our kids are, you know, 99% are chronic developmental disabilities. So it's, you know, the changes aren't going to be huge within a 30-day period. And if the PTA, if I have to, if there are kids that maybe we don't see but once a month. So then it has to all be on a physical therapist's schedule instead of a PTA schedule. Because you have to check in on them every time, every 30 days anyway. So that makes that kind of difficult. So that's my proposal, is to try to get this stretched out a little bit longer. And it's not like we aren't communicating, and because we're constantly communicating every day almost, because we're there together. But she, you know, she has a full caseload. I had a full caseload, and we're part-time. And the other we don't have full-time therapists. It's too hard to get therapists down here. So I don't know, it's kind of part of that whole chronic condition, similar to students in a school district setting. Is there a way to kind of meld us into that outpatient, pediatric, OT, PT clinics? I know OTs are different. I mean, they don't have that rule. And so we haven't, fortunately, had to deal with that in our setting with the OTs. But it is problematic with our PTs.
Yeah. And I appreciate you framing that, because some of that is going to be in some of the, like, I think the next 3 sections we'll see more of kind of the what's being impacted by your situation.
Right.
Yeah.
And we're a nonprofit, and we have 70% Medicaid. So, you know, kind of keeping our head above water all the time. And so we have to look at the whole spectrum of it.
Thank you. Jeannie?
In number 7, the last line in number 7 says an SPT's documentation. I think it should say the SPT as well as the SPTA. So the first part of the comment addresses SPTA and SPT, but the very last line does not.
Okay. Thank you. I know Deirdre has queued us up, so I'm going to also go ahead and scroll into the next 2 sections. I know Joni had flagged the use of treatment previously as opposed to intervention. Other thoughts here?
I don't know if it's a good thought, but on A, you know, progression or regression, is there a definition on that? You know, does it, I mean, is there a quantity that needs to be, maybe that's not important.
Or why was it called out beyond status if there isn't like a specific okay. Thank you. Joni?
On B, I don't even know what that means. I think my second comment to that section might be some generic language, an accurate documentation of the services provided and billed.
So is there a way that we can be kind of higher level as opposed to having to line by line the content? Okay. What else? I think while folks are reflecting on that, I'm gonna jump to reassessment. Scott?
Just going back up there on that part, let's see, 1E says changes in the plan of care. To me, that kind of reads that each visit, we have to document a change to their plan of care. And there may not be any changes that are needed. Is that how that reads to any of you, or?
Yep.
Yeah, I had the same comment. To changes to the plan of care, if any. Adverse reactions to treatment, if any.
Okay. Thank you both. I can always loop back, but I'll put this on the screen for reassessment. And this is one of the pieces that was updated, I think, more recently. But it is something where Deirdre was speaking to pieces of this and applicability in different care settings. I'll turn it over to Jeannie and then Joni.
So I was just going to echo the same thing that Deidre just said about the 30 days, 60 days. I don't, she used the context of, in the clinics where she's working with pediatrics like once a month. I was even thinking from my experience in an orthopedic outpatient, if we're seeing a patient that's only coming in once every week, again, in a 30-day turnaround, they've only been in 4 times. So as I read through this before we got to today, I was also putting together those practice areas where they're seeing patients every single day. So a skilled facility or an acute setting. So maybe what this needs is just some differentiation based on treatment settings.
Okay. Joni.
I'm wondering if it's time to, instead of using the terminology reassessment, that we someday, hopefully, maybe Oregon will have a Model Practice Act, and Model Practice Act language is going to be reevaluation, same as terminology that Medicare uses. So that'd be one piece, just changing that whole piece to reevaluation. Secondly, maybe even having reasons to conduct a reevaluation, because Model Practice Act language is going to be perform and conduct a periodic reevaluation. So then here you could give the reasons you would do a reevaluation, and Medicare gives 3. And then I'm going to echo the comments of doing a reassessment every 30 days. Again, a periodic reevaluation would allow the therapist to have the autonomy to choose when they're going to do that, when they meet one of those 3 reasons to conduct a reevaluation versus having it prescribed by a number of days or a time frame.
Okay. I have Erin, Jennifer, and then Scott, Alan, and Cheyenne.
I really like what Joni just said, and I think that would be really helpful. I was just thinking as I'm reading this with the day limitation, that's been a problem in pediatrics, just with frequency with which we might see individuals, and just thinking about some of the best practice guidance that's coming out. There's, a lot of redefining discontinuation versus discharge and how frequently we might see people, and encouraging us to monitor kids, maybe once every couple months or at certain points of time in development and that sort of thing. So I think what Joni said could align well with that.
Thank you. Jennifer, then Scott.
Yeah, so I just also wanted to jump on what Joni had to say. I think that using the term reevaluation is going to be a lot less confusing for people. We've got progress note, reevaluation, reassessment, all these different 30-day assessment, all those things. And then also, you know, anything that gives the PT, I think really needs to have the autonomy to do those changes, you know, that they would be the ones to determine when a reassessment is needed by the PT. And I'm just saying again, since last time when this was all, you know, became a rule to begin with was 20 years ago. And I think there was maybe not as many PTs available. A lot of times the assistants would end up being primaries. So those kinds of issues, I kind of think what was driving this to begin with, but I also think things are moving a lot faster now and just issues are different. And I work in outpatient ortho as well as skilled. And so I don't see a problem with like maybe not even having days, how many days to go. So.
Okay. Thank you. Scott, and then Alan on deck.
I just want to second on the verbiage of the reassessment. Think we have to be careful to use the word reevaluation because that's a separate code to charge for. And we don't want therapists thinking they should charge every 30 days, do a new billing. So it should be like a recertification or a progress note verbiage, or reassessment works for me. And then I also second the 30-day rule. I think they should get rid of that or extend it out much further.
Okay. Alan and then Cheyenne. And then
Kind of going back to, I think it was Jeannie that was talking about, I mean, this is somewhat, I'm bandwagoning a little bit here, but, you know, we're talking about pediatrics, rural settings, nuanced outpatient scenarios, and then even just to throw it in there, maintenance therapy scenarios for instance, folks with progressive neurological conditions. You might be seeing them to maybe twice a month, maybe 4 times a month, maybe. So looking at verbiage there, I think treatment settings and scenarios would be something, how do I put it, just keeping a broader range to work within. But certainly the date, this is a hard question to answer because if we're talking about maybe getting rid of the time frame altogether or adjusting it for certain scenarios. And that's why the board makes the big bucks. Leave it at that.
thanks, Alan. Cheyenne, then Hamina.
Yeah, I agree with other people's comments about being more specific with the language that's used between a reevaluation, a reassessment, or a progress note, and having it be more reflective of what clinicians are experiencing in their clinics. Because for me, I recently had a situation at the long-term acute care hospital where they were asking me to write progress notes, and I really had to lean on the board laws to guide my decision making for this. And I assumed that this is what it was referencing, but it was a little hard to go through that process. I also think being really clear of what is needed when you're doing either, if it's considered a reevaluation or a progress note, being really clear of what determines the difference between those two things is important. And then in number 2, the language where it says a physical therapist shall personally examine the patient. For me, I needed clarification on that specific language because when I was being asked to write progress notes, I was being asked to write progress notes for patients that I had never actually seen in person. And so I think making that very clear of like an in-person or hands-on assessment, I think would be beneficial for PTs in the future.
Okay. Thank you. Hamina, then Scott.
I wanted to echo some of the comments that have been made before as well. This is where I got feedback from my team asking to please extend the 30 days. That's the one thing that I got asked the most. for two reasons. Also, Medicare aligning with Medicare guidelines, one. And then also when the therapist has to see the patient, we remove the possibility of using our PT assistant. So, you know, some insurance will require authorization periods. So we have a patient that gets evaluated, you're waiting for 2 weeks to get that authorization back. Patient gets back, you got approved for, that patient maybe gets to come once or twice before they have to have another progress note. And it's just a lot of paperwork and, you know, and after those 4 visits, by the third, you have to do another progress note. So it's, it will be helpful to increase that timeline as well.
Thank you. Scott, then Cheyenne.
Just a couple of points again on one on the 30-day rule. Gosh, and I think I'm losing my train of thought. We're constantly reassessing them, and the requirements on the daily note kind of justifies that. So it's like, why do we have to have an official note every 30 days? And I think Medicare only requires it every 10 visits. They got rid of the 30-day rule. And then another thing on that number 2, where it says you have to examine the patient personally. Well, if you go to the discharge rules, we have to discharge patient if we haven't seen them for 30 days, or we have to do a progress note. But how can you do a progress note if you haven't personally examined the patient?
Okay, thank you. Cheyenne.
Yeah, speaking more to the acute care setting, there are a few lines that have discussed like reassessment and things that the PTA is allowed to do. So earlier where it had stated that a PTA could provide treatment on the day of reassessment. And then here where it says a PT could delegate the PTA to gather data for the reassessment. In at least at the long-term acute care hospital that I'm at, it wouldn't be reflective of the practice that we would do, because then that would be 2 visits from 2 providers on the same day, which from a productivity standpoint, just wouldn't be as efficient. So I'm not sure if how other people feel in other practice settings, but for myself, I wouldn't see that as something that would be feasible or efficient to do in an acute care setting.
Thank you.
Can I ask? I'm sorry, maybe Jennifer goes first.
I just wanted to follow up again on the comment about the physical therapist directly examining the patient. In the setting that I work in anyway, I'm not sure if this is true. I don't think it's true in skilled, but all of my notes go to the PT. So they have to sign off on everything. It's a pain in the butt, but so yeah, I mean, I'm collecting the objective data, putting my recommendations, and then the PT is always co-signing it. So.
Pamina?
That's exactly what I was gonna say. You know, if in the case of, let's say it was a patient that missed an appointment and was supposed to see the physical therapist, but then missed that appointment, comes to the next scheduled appointment, which ends up being with a PT assistant. And then you discover that the progress note was not done. The PT assistant can perform that gathering of data, and then the physical therapist can co-sign that note. If that was specified, I think everyone will feel better. Mm-hmm. Because that happens. It's very common.
Jeannie.
So I really appreciate this conversation that's happening, but I guess I'm hearing a lot of what's going on in the clinic, but is anybody making a suggestion here? I'm missing what the suggestion is. Is the suggestion to just take that part out, that the PT does that personal exam, or are we suggesting that it look a different way than it does now, but that the PT is still in contact? My personal experience and not only my own clinical experience, but having contact with lots of PTAs relative to my work in education is that I think that a lot of clinics are using what Jennifer described, which is the PTA is gathering all of that information for a multitude of reasons. They were the person that treated that patient that day, and that information is just being passed to the physical therapist. So back to my original point, if we're making a suggestion, I would like to suggest that we're losing that part of the comment that says the PT shall personally examine the patient.
That you think that it should be removed?
Correct.
Yeah, and if I know we've talked about the 30-day rule, but if for some reason a timeline stays, I think that suggestion would be really great, because then if PTs could then co-sign notes and look at and have discussions with the PTA of what's going on with the plan of care, I think that it would ease the ability for providers to see more patients, because PTs could then see their patients, PTAs could see their patients, and it just seems like it would be a more efficient process for the clinical environment.
Joni?
Just to throw a wrench in it, and for me, I look at that and think it should be transformed to re-evaluation to line up with the Model Practice Act language as well as Medicare language, and kind of get rid of this reassessment terminology.
So kind of a couple of different pathways and then description of how it is impacting practice. Okay. I'm going to be, some folks have touched on it. I'm just going to scroll because this is sort of the companion as far as documentation of reassessment. So I'll put this up. I think we've gotten some comments that relate to this as well. And obviously based on what would happen in the standards, then the documentation, there would need to be parallels. Any specific comments or flags here in addition to what's been mentioned?
Just to add, I think because if a PT has to do like a personal reassessment based on the line above, then where it says at the end of this on number 2, where a physical therapist assistant may prepare the progress summary for the patient's status and performance of a reassessment, I think that gets a little confusing, because it's like, well, if the PT is doing the personal reassessment, but then the PTA could prepare the summary of how they did, I think there just needs to be clearer language of what role and responsibilities is the PT and the PTAs in a reassessment of the patient. And maybe this goes to Joni's point where it's just there's too many words and too much confusion, and maybe we should follow what would you say it again, Joni? You said model practice?
Well, when we think about Model Practice Act language, right, it talks about one of the responsibilities of physical therapists is to conduct a periodic re-evaluation. And so as a trickle down from that, because I'm so hopeful that someday Oregon will have a Model Practice Act, that the rule then would match a Model Practice Act, which talks about a re-evaluation. And I think the other advantage of that terminology is that it matches up with Medicare. Did that help?
I think maybe some people don't know what the Model Practice Act is.
Yeah.
Maybe that might help. Well, Michelle, just put it in there. Thank you.
Yeah. And it is, it's model language that's been developed by the Federation of State Boards of Physical Therapy as sort of best practice and model language, or based on sort of national and to an extent international practice. But that's the copy that takes you to the landing page, and it was recently updated to the 7th edition. I think one other note is that the Model Practice Act is predominantly statutory language, which would be put into place by the legislature. What we're looking at here is the rules that hang off of the structure of the statutes. So there's some things I think that based on the way our statutes are written, the rules could cascade and we could use some of those adjustments. But when we're looking at things on, particularly terms on reassessment, if that's how it's called out in the statute, then we would have to continue to use that language unless there was the adoption of the Model Practice Act language by the legislature as part of the new statute.
And I think Scott already talked about it, but just, switching to a reevaluation terminology can be confusing because the reeval charge, as I understand it, is not something that should be used at every progress note, or, it really is when there's a significant change in status and you need to do a full reevaluation. So I'm just concerned about seeing that in the, all over the rules.
To be very clear what's meant in each context. Taking that into account. Scott and then Joni.
Joel just kind of commented on it. If we change that to reevaluation, does that mean we can start billing reevaluations every 30 days or 60 days? And if it doesn't, then that's how a lot of people will interpret it, especially in the outpatient world.
Okay.
Well, let me be clear that when I say reevaluation and periodic reevaluation, that removes the 30 days. Like it gets rid of that. It's a periodic, and it's based on, there's three things that Medicare, failure to progress, significant change, and there's one, new clinical findings. So that's why you would do a reevaluation. And then if you wanted to bill for it, but it wouldn't be based on a time frame.
Would we need rules on reevaluation and recertification then? Recertification mean your plan of care is ran out of date.
Okay.
I mean, I don't, sorry.
Go ahead, Johnny.
I was just gonna, I think recertification is very different than reevaluation. I mean, recertification is just a time frame. It's not necessarily a change in patient condition. And the only reason you do a certification would be if you have a change in your long-term goals, or if you've run out of time on your certification period. That's, to me, very different than a reeval.
Yeah, and I think Cheyenne had noted, because of the state government, the chat messages go to me from the group, but Cheyenne has noted that it seems very important to provide a clear definitions for all of these terms, right? Reassessment, reevaluation, recertification at the beginning. So read that into the record. I will move us to discharge.
So I just wanted to throw one more thing out there before we move to discharge of something, because I look at the rules all the time and I get a lot of questions about what's not in the rules. Some states have this rule and some don't. How many PT assistants can be supervised by a PT? There definitely are settings where they're like skilled nursing, where there's a lot of physical therapist assistants. There may be one or two PTs, and they may have seen the patient once, twice. They don't even know the PTAs. So that question comes up from both sides of whether that's something that should or shouldn't be there.
Any comments on that from the group? Scott? No, I bet you're here for discharge, right? Yeah. And any comments to Sherry relaying other comments that she's received? Okay. Then I'll turn it over to Scott and discharge.
Thanks. I can only speak basically for outpatient for the most part, but the very bottom one down there, the within 30 days, I would like to either see that extended to at least 60 days or done away with altogether. it's very difficult to keep track of patients. Some just kind of fall off and you forget about them. And some of us don't have the best principles put into place to keep track of them. But I'm also not a big fan of discharging the patient, period, because it creates a disconnect from you and the patient. And sometimes when you're talking to a patient, you're like, okay, should I discharge you today? Then they're like, oh, does this mean I can never see you again? It's this whole disconnect. And we, and maybe PTs and speech therapists, are some of the only professions that discharge their patients. You know, acupuncturists, massage therapists, chiropractors, doctors, they don't discharge their patients. And if they have to see them for a new thing, then they start up a new plan of care. And then if we discharge them too early on accident, and then they come back like a week later and, oh, my knee pain returned, do we bill for another initial evaluation? And I have a whole thing another therapist wrote up on why we shouldn't discharge them, but maybe I'll just send that to you guys through email.
That'd be great, Scott. Thank you. Thank you. Joni?
I mean, Scott, I don't necessarily disagree with you, but physical therapy is based currently on episodes of care. I mean, this goes all the way back to CMS. It's not just the state of Oregon. I mean, but I do appreciate what you're saying. But yeah, at this point, we still have to discharge patients.
Yeah, I see that as based off, that, but it's kind of an old school of thought, and that's when we were under supervision of a doctor, and now we are, the first line of defense a lot of times, and people come see us without referrals.
Okay. Good perspectives. Hamina? And then Erin.
I just wanted to second Scott. That was also feedback that I got from the team. Especially when you have patients that they're doing great, but you want to have that follow up in 2-3 weeks, to see if they're for sure discharging or not, and then those fall through the cracks. And so if you're looking into maintaining compliance from all therapists, this is something that probably it's being affected just for the way it is written. It's difficult. We do have a system in place to be able to track down patients, but it's not for all clinics, depending on the EMR that you have. So it was a request that maybe that last visit could be also a discharge note in the case the patient doesn't return. So then that would take care of it. Or even if adding a blurb to all of your templates where it would say, if patient does not return, this is considered a discharge note, if that would be, in compliance with the ruling. But so then you don't have to go back and write a separate note, something, to look into.
Okay.
Hamina, that has come up quite a bit, and I do agree. A lot of people do that. It's not in the rules, but maybe it should be, because a lot of people do exactly that statement like that on the bottom of their chart note.
Erin, then Joni, then Cheyenne.
Yeah, the discharge, this component is just really doesn't apply very well in the school-based and early childhood settings when you're parts of your plan of care are a year long, for example, and contact just looks so differently. Especially, I know we're not necessarily at the next section yet, but the 30 days component is just not a thing. I know it says or last contact, but that has come up a lot as problematic just for how the practice setting works.
Okay. Thank you. Joni, then Cheyenne.
Just a couple comments. So remembering that Medicare does require a discharge summary be written. And my second point would be Medicare does not, and I don't want to offend anyone here, but Medicare does not allow physical therapist assistants to write the discharge summary. They can write pieces of, they can provide data that the therapist or the clinician would use to write the discharge summary. So I'm wondering if that needs some clarification.
Okay. Cheyenne?
Yeah, at Randall Children's, the therapists don't write discharge summaries. At the end of our treatment notes, it says that if a patient is discharged, this will serve as the discharge summary, which I know is a little different because based on number 3 under standards of discharge records, it does say that it's not required in an acute inpatient care setting if another licensed medical professional provides that documentation. So I was just gonna talk about what Jimena was saying about how this would impact clinicians in different environments and kind of how we're doing it at the Children's Hospital.
Thank you. Other thoughts on discharge? Standards or record? I think bringing in something else that has come up is when you have discharge or don't have discharge, the definition of patient, right? And when the provider, practitioner, patient relationship ends or doesn't end is tied into when discharge happens as well. So there may need to be some clarification of that tied into this, depending on what evolves from here. Okay, I'm gonna just a couple more sections. Any thoughts or comments under screening services? This one is a relatively recent update during the pandemic years. Jeannie.
I was a little confused by 2 and 3. Physical therapist, conduct or perform physical therapy screen for a person who is not currently a physical therapy patient. I get it. Only a physical therapist may perform physical therapy screening for a current patient. I don't understand. Are they 2 different things?
I think the intent here was that in the case where it's somebody that you're currently seeing, and they mentioned like the completely different body part or completely different ailment, that in the course of that you could do a preliminary screening and say that's something that there may be some benefit, but you may need to go back in and through that gets into the process of the initial assessment and everything that you may be able to do in that session with them.
Right. So is there some way to make that a little more clear, I guess?
Okay. Thank you.
Thank you.
Jeannie? Or no, okay. Any other thoughts on screening? Jennifer?
Yeah, just a quick question. Is there this used to always be a discussion, and I'm not sure if anyone else runs into this, but screening, when you're doing screenings, there's no rules as far as like how much hands-on people can do and things like that. And I always, I don't know, tread that line carefully of, are you putting your hands on people? Are you putting a gait belt on and having them walk where they could potentially fall? This is all the discussion that goes on. And I guess my question is that still a discussion, or is that, worrying too much about things? I guess that's always the idea. It's like, can I go in and do a transfer with someone who's a max assist transfer, I don't know.
Okay.
Gray areas.
Okay. Kathy?
I definitely agree with Jennifer's point. I kind of have a mindset in the acute care hospital that screening is a chart review. Because if a therapist lays eyes on a patient, they start to do an assessment, and then they're going to make recommendations. So I think it is a very fine line of when you go from screening to really using your skills and starting to assess the patient.
Thank you.
I think part of this, where screening came up initially was seeing people out in the community where, you know, you're at an event or you're at some sort of place where, you know, or someone comes into your clinic and just says, hey, I wonder, do I need PT? And looking into that, and people were saying, well, if I just do this at a sporting event, is that an evaluation, or does that count as treatment? So I think that's kind of where that screening sort of started conversation. But and I feel like it's sort of an ever evolving topic and question.
Yeah. Erin.
Yeah, screenings happen a lot, especially in the school setting. And I don't think there's any problem with anything that's outlined here. The question that Sherry's heard a lot is it really more has to do with the special education law and regulations around consent and parent consent. Since you're providing screening to their child, you have to make sure that they know you're doing that. But it is something that happens a lot.
Okay. Thank you.
And Erin, now that you brought up consent, somewhere in the documentation rules, Michelle doesn't need to go scrolling all back through it, but we've talked about obtaining consent for treatment and documenting that somewhere in the rules.
Thank you, Sherry. Telehealth. I will say that in this division, it's a little bit different than what many states do. And we do get questions because this essentially says you can do it if your patient is in another state, but you need to make sure that that state says it's okay. So I think maybe clarification on where the patient is versus where the practitioner is may need to be aligned or tweaked a little bit so it's more clear for folks. Any other thoughts on this? Then I am happy to bring up the very last section in Division 4. Any thoughts on the standards for community education, prevention, health promotion, and wellness services? And I think this is also to Sherry's point earlier that this rule evolved out of questions about, well, what if you're in a group setting, right? You know, do you have to go through all of the processes, and when don't you?
We actually had a whole rules advisory committee just for this rule, which I kind of think maybe I don't know how much time from now we might need again. Comes up a lot with like working with athletes, high school athletes, kids in the community, you know, people who are trying to help out their communities, but nervous to do so because they're not really sure what they're allowed to do as far as the board.
Okay. Well, that folks think about that is that we are at the end of the session today. So appreciate your time and efforts in this. We are going to take the recording along with the written comments that you, those of you that have submitted input. If something occurs to you in the middle of the night, when you hear the ice crashing off the roof, please feel free to continue to send in any thoughts or comments that occur to you. We are going to process all of this, put it into a single document, probably with some markup. We'll probably flag suggestions. In some cases, we have branch alternatives where one person suggested doing an update in this direction, somebody else suggested going in this direction. So we'll show some of the branch options to get it documented to be able to reflect back to the group. It will probably take us a couple of weeks to be able to get all of that together and back out to you. So what I may do is, if it's okay, wait until we've had a chance to put that together a couple of weeks before we schedule a next session with you all. Probably even send the document out and schedule it at that time. So we probably won't group again, frankly, until after we close the renewal season. It is most likely that we would meet again in April, but we would be meeting with the next step, which is the aggregated information where we can start making some recommendations back to the board. With that said, I said the R word, renewals. We do plan to open those up. Some of you may have already discovered that we've had it on soft launch, as they say, soft opening. So you can go in and renew. Of course, relating to renewal is your required CC. And just a reminder that your work on this committee counts toward the maximum of the 4 hours of committee work to satisfy your continuing competency requirements. So Sherry is tracking and we can produce that certificate. So if you want to use the 4 hours for your committee work here, we'll produce the certificate, get that in, and you can use that. So don't renew until you have your certificates if you want to use those hours. And
So
with,
can I, oh, go ahead. I just want to say one more thing about renewals. If you, one of the things that comes out on renewals is that everybody has to take a required pain management class. It would be super helpful if everybody could pass along to their colleagues. There's one pain management class. It's offered by the Oregon Pain Commission. Everybody has to take that particular class. We always wind up getting people to take really good pain classes, but they're not the class they have to take. So the more that could be disseminated out to people, that and actually I took it this weekend. It's really good. So that everybody takes that one class. That would be really helpful for us.
So any kind of final questions or comments for us? All right. Thank you, everyone. Appreciate your time. Go back to your families. Cheers.
Thank you, everybody.
Thanks, everyone.
Thank you.
Thank you.
Safe.